Thanks a lot. Now, I would like to introduce our first speaker, Dr. Wasundhara Bhad. She is, for me, Vasu, because we are from the same college, GDC Nagpur. Dr. Wasundhara Bhad is a professor and HOD in the Government Dental College, Nagpur. She has total teaching experience of 30 years and postgraduate teaching. She is a postgraduate guide for last 16 years. She is also a PhD examiner and guide. And I would proudly say, all of us know that she has received the Best Teacher Award of Maharashtra Health University, Nasik in 2014, and the prestigious award, Dr. B.F. Dewell Clinical Research Award of Best Original Research in 2017 by American Journal of Orthodontics in Washington, D.C. She has 42 international publications, 10 national publications, and 4 patents and 2 books. And she has many times, like we have heard her many times, she has been invited speaker in all the PG conventions and most of the conferences. And her well appreciated research contribution is in accelerated orthodontics, micro osteoperforations, sleep apnea management. Then we all know the diagnostic angle, W spring. Then class 3 management by modified reverse twin block appliance, and many more appliances. Now she is member board of studies, MUHS, Praura University, and Savangi College, that is Datta Mege Institute of Medical Sciences, Savangi. And she is on review board of Journal of Indian Orthodontic Society, Journal of Contemporary Orthodontics, Angle Orthodontics, and Public Library of Science Plus. So I invite Dr. Wasundhara Bhad, and without wasting any time, we will start with the first important topic of this session 2 is diagnosis and case selection for myofunctional appliances. Over to you, Dr. Wasundhara.
Thank you, Dr. Gauri.
To share the screen.
Yeah.
1 minute,
Yes.
ma'am. Ma'am, you are the co-host now. You can share your screen.
Okay, I'll do. Thank you, Dr. Gauri, for an elaborate introduction. Yes, we are friends. We are alumni of GDC Nagpur. At the onset, I would like to thank the office bearers of the Indian Orthodontic Society, our president, Dr. Silju Matthew sir, and our dynamic dean, Dr. Sridevi madam, for giving me this opportunity. I also would like to thank the organizers, Dr. Ajit Kalia and Dr. Salil Nene, for inviting me for this program. The theme of this program is self-explanatory, orthodontic finish line, and it has been very well explained by Matthew sir in his presentation. The theme itself is self-explanatory, and now all the students are at the finish line just to cross it well prepared. So the first exercise of the first day of the MDS exam is functional appliance. The path is very long, but I would like to take it or constrain it in the time allotted. So I'm always proud about my alma mater, Government Dental College and Hospital, Nagpur. And that's the department. The day of exam, well set. All the trays are ready for all the exercises. The records are displayed for the examiners to go through. The student is ready for the examiners and the exercises to start. And that's how is the scenario on the day of the exam. And we make the cases for the functional appliance, sit on the chair, and the examiners go through it. So the examiners will do the clinical examination, will go through the records and select the cases to be allotted to the exam going student. So that's how the picture is. So the case is allotted and the records are given to the students, the study model, the photographs, the cephalogram, the OPG, and the MP3 radiograph on an IOPA film. So with these records and the patient, the student is put to the exercise, the clinical examination, and analyze the records. And the time allotted is 30 to 40 minutes. So what to do in this 30 to 40 minutes? If you are well prepared in the 3 years treating patients of functional appliances, I don't think there is any problem. No problem at all. You'll start the records, take the case history, and do the clinical examination, finding out what is the age of the patient, what is the physical characteristics in this patient that the patient can be treated at this particular stage by a functional appliance. You do the clinical examination, look at the face type, look at the mandible, look intraorally, examine it. How is the maxillary arch formed in a transverse direction? Basically, we are concerned with that. So is the arch narrow? Is there a habit responsible for it? So that we'll try to ask in the history and evaluate in the clinical examination. Then we will do the functional analysis. Then the model analysis. You don't have to go through a thorough model analysis. Here we just want to find out, is there a transverse discrepancy? By doing a Pond's index, the Lindaha's index, or a Chadda's index to find out whether the arch is narrow or wide and is any etiology present behind it. Then we do a cephalometric analysis, find out the skeletal discrepancy. OPG is there. We have to look for many characteristics in the OPG that I'll be taking up and the MP3. So after doing a thorough case history and a clinical examination, and you say, yes, I am ready, then the question put up is the patient indicated functional appliance? You may think over that patients have been called for the exercise. So yes, they indicated. No, it has to be justified. And then the question is, if indicated, which functional appliance and the mode of action of the functional appliance. So let's come to the first question. Is the patient indicated for functional appliance? So you can put an answer in one word, yes, but no, that is not required. The answer has to be justified. So let's revise the indication of the functional appliance. The functional appliances are indicated in actively growing patients, mild to moderate sagittal skeletal discrepancy, posteriorly positioned mandible, small size mandible, horizontal to average growth pattern, upright or linguolytic mandibular incisors. There shouldn't be no severe crowding or rotation that interferes in the path of forward movement of the mandible. Then orofacial dysfunctions were the present. They are the best cases for it. The V2 does it become positive, and a good patient's compliance should be there, then only your appliance will work. So let's see the first indication, actively growing patient. How do we come to it that a patient is actively growing? From chronologic age? No, because in 60% of the individuals, the chronologic age does not relate with the skeletal age. We are going to treat the skeletal malocclusion. The skeletal bone development, the bone maturation should be there in an active phase to bring about the correction. So why a skeletal age is important? Because every individual shows variation in timing, variation in growth duration, and variation in growth velocity. And therefore, we need to assess the skeletal age. Now, how do we assess the skeletal age? You have an OPG. On an OPG, apart from looking at the ramus height,
Ma'am, I think you have stopped sharing your screen. And muted herself. She has muted herself. And you have muted yourself also, ma'am. You have muted yourself, ma'am, underneath on the lower left corner. Just check. Lower left corner of your laptop, madam. Ma'am, you have muted yourself.
मॅम तो दिसत नाही आता पॅनलिस्ट.
We are sorry for this technical glitch, but madam is just joining back. Please stay glued to your laptops.
can you ask them to make us host? Make us the host, Salil.
You are the co-host, ma'am.
It is there.
Yeah, we can see your screen, ma'am, and presentation.
Yeah. Sorry for this technical delay. So yes, so going through the OPG, on the OPG, the dental calcification of the mandibular canine also can be assessed, and this is also one of the method for assessing the skeletal maturity. And it has been seen that there is a strong correlation of 0.85 with the skeletal maturity indicators of hand and wrist. So this also the students should try to see whether it is in the initiation stage or it is in the acceleration stage. The best stage is stage G, as given by Demirijan. He has given 8 stages, and of which the G stage coincides with the accelerated growth spurt or the peak of the mandibular growth. Then we have the hand wrist radiographs, and the Fishman 11 indicators are well established, and many of the institute still take an hand wrist radiogram to assess the skeletal maturity, but it has an additional exposure. That is one of the drawbacks. Then cephalogram, we already have it, and therefore cervical vertebrae maturation is an established assessment staging which has been given by Lampasky, then later modified by Hessel and Farman into 6 cervical maturity index, and then in 2002 McNamara, Bassett and Frenchy gave 5 cervical maturity stages. So they are based on the morphology of the cervical vertebrae, and based on that you have to find out in your patient what is the stage of skeletal maturation. The best is CS3, where there is a peak of the mandibular growth, but always your patient will not be at that peak. It can be in CS2, so it is 1 year ahead, or it can be in CS4, where only 10 to 25% of the growth is remaining, and then the peak has occurred a year back. So depending on the stage of skeletal maturation, where your patient is he in the initiation stage, an acceleration stage, or in the deceleration stage, you have to plan your functional appliance. You just can't say no to a functional appliance. They work, but accordingly, if the patient is in a CS4, or it can be in a CS5 also, then during this stage, your thinking process should start. I will give a functional appliance which will work 24 hours, which will take advantage of the best possible growth present in this particular patient. So we have to defend on the basis of skeletal maturation and the growth remaining, which functional appliance to be planned in this particular patient. Then the middle phalanx of the third finger, which is now a very routine, a very convenient method, because you take the radiograph on an IOPA film, and this has been given by Hag and Terenger and later modified by Rajgopal and Kansal. And this is routinely followed in most of the practice and in the institutions. And the FG stage of it, where the epiphysis is equal to the diaphysis, that's the stage of acceleration. So this is the best time to catch hold of the growth over here. But later on, at the G stage also, maximum point of growth spurt curve is there before the capping and fusion of the epiphysis with the diaphysis take place. So you have a growth in hand, and your appliances work well during this period. So, but one additional information apart from this is to add to your final viva also, there are, since the cervical vertebrae maturation staging is a subjective method, at times you get a concavity on cervical vertebrae 4, you may not get it on 3 also. So there are very precise methods coming up. Quantitative cervical vertebrae maturation assessment is also done by Mito, and he gives us the exact value. And there are biochemical indicators. A lot of work is going on in this direction, which will show us whether the patient is in a pre-puberty or in the puberty or in the post-pubertal phase. And these biochemical indicators are assessed in serum, saliva, and GCF, and the IGF-1, IGF-2, and the alkaline phosphatase levels can be assessed. You get a value, and accordingly, you will come to know at what stage of maturation the patient is. We did a study long back in 2010. So according to the skeletal age assessment or skeletal age maturation, your timing of treatment will be, your patient will be in the early phase, or it may be in the late phase. It could be a 1-phase treatment, or it could be a 2-phase treatment. Treat now or wait. So these are the questions with the timing of the treatment, and there's a lot of debate, a lot of studies are there on it, and one has to go through it, read it. So this is a critical review, one phase versus two phase. And one thing to remember, the body has given a very strong statement. There is a genetic paradigm. Often a question is asked, do you make the mandible grow? Mandible will not grow beyond the genetic potential. Whatever is the genetic blueprint, you make the mandible grow to it. You eliminate all the restraining factors which has not allowed or restricted the growth of the mandible, and there the mandible will catch up to its genetic potential. That is what the functional appliance does. Often for early treatment, the parents are more concerned because they feel that they are disturbed with the psychosocial problem, or they often feel that the anteriors, which are more proclined because of the increased overjet, are prone to accidents. So there is another systematic review, a latest systematic review, 2018, outcome of early class 2 malocclusion. And this systematic review states there is insufficient evidence with respect to the early class 2 treatment in respect to soft tissue profile, the quality of life, incidence of trauma, and treatment related to the cost. And the bottom line is start late and complete early. So you start the treatment in the late mixed dentition, early permanent dentition, take the growth in hand so that you make the mandible grow, and then finish the case with a fixed appliance. So that will be a one-phase treatment. If you start the treatment in the early mixed dentition or a mixed dentition, then you may have to stop in between. And then after the eruption of the permanent, you then do a finishing and alignment of the teeth. So that will become a two-phase treatment. So the preferred is, or an accepted is, start late and complete early. That is, do it in a one phase only. After assessing the growth status, then you do the cephalometric analysis to study the sagittal discrepancy, to study the vertical discrepancy, to find out the proportion of the jaw bases, the dental inclinations, and the dental heights. So these are the different parameters to study the sagittal or the anterior-posterior discrepancy. And we all know that A and B is not a reliable indicator, because with rotation of the mandible, the B point also rotates. You get an increase A and B, and that is not a true sagittal skeletal discrepancy. Therefore, a beta angle is done, the W angle is done, and more preferred is the NA linear and the NB linear. You measure from an N perpendicular, you measure the A point of the maxilla linear distance and the B point on the mandible linear distance. And this difference is almost around 5.3 to 6 mm. From this parameter, you come to know also whether your maxilla is ahead of it, that is prognathic, and how much retrognathic your mandible is. You come to know from this discrepancy, from this parameter, NA and B linear. Then the vertical discrepancies, you'll come to know whether the growth pattern is horizontal, average, or vertical from the SN to MP, FH to MP. You should also do the base plane angle. How are the bases related to each other, the maxilla to the mandible? Because if the bases are convergent, if this angle is less than 25, they are convergent bases, and functional appliance works best during this case. The bases can be convergent, the bases can be divergent, the bases, both maxilla and mandible, can rotate caudally also. So how is the bases related to each other? How is the rotation and the relation of maxilla and mandible? We come to know from the base plane angle, and further you can study it from palatal to occlusal plane, the maxilla, and the occlusal plane to mandibular plane, the mandibular rotation of the mandibular base. Then inclination angle, this angle basically is very important in cases of average to vertical growth. Because what has made the mandible rotate clockwise, we need to find out. Is it the palatal plane at fault? So this inclination angle, if increased, it could be because of the PNS coming inferiorly, which in turn is leading to mandible rotate clockwise. So inclination angles should be studied. Then the Rakosis functional analysis, the saddle angle, the articular and the gonial angle. The saddle angle, if increased, show a posteriorly positioned condyle posteriorly positioned glenoid fossa, and prognosis in such cases is poor. But the articular angle, if shows an increase, articular angle is sella, articular, and gonial. If this angle is increased, then it shows a retroposition mandible. We want to find out this mandible, which is retroposition or retrognathic. So articular angle will tell us whether it is retropositioned or not. Then to find out whether it is retrognathic, whether the base itself is small or not of the mandible, then in that case, we need to do the McNamara's analysis and the Schwartz analysis. Now, this Schwartz analysis has given a proportion. You measure the anterior cranial base length, SCN, and the mandibular base is anterior cranial base length plus 3. He has given the ratios 21:20. So accordingly, it comes anterior cranial base length plus 3, and that will show us whether this mandible is retrognathic or not in relation to the cranial base. You also come to know the ramus length and the maxillary base length also from the Schwartz analysis. Then dental inclination, yes, we know that ideal cases are where the lower incisors should be upright to lingually tipped. So the lower incisor to NB or the IMPA, we are more concerned with. But if they are proclined, that also doesn't mean that the functional appliance is not indicated. Then how do we overcome? That we should think about. How should we overcome it so that to prevent further proclination from taking place, and later on when we will switch on to the fixed appliance therapy, then we can correct this proclination. So lower incisor inclination, upper incisors mild procline are the best cases because the functional appliance have a retrusive action on this upper incisors because of the headgear effect. Then the soft tissue parameters, the nasolabial angle and the lip protrusion. Yes, the nasolabial angle, you need to study the upper and the lower nasolabial angle. Why? Because at times when there is a proclination of the upper incisors, your VTO doesn't come that good. We will not say at times a positive VTO. Why? Because it gives a Bimax look. But that Bimax look can be corrected after the functional appliance therapy during the fixed appliance treatment also. So that your thinking process will start accordingly. If my nasolabial angle is acute, then in that case, why it is acute? Is it the upper incisor severely proclined? Will I need a second phase of extraction with a fixed appliance? That will be then our answers to the further questions. Dental heights, yes, the posterior dental heights are decreased when there is a true deep bite. Now, class 2 malocclusions are often associated with deep bite. Now, is this deep bite a true deep bite or a pseudo deep bite? True deep bite is because of the infraocclusion of the posteriors, whereas a pseudo deep bite is because of the supraocclusion of the anterior. So that will give an indicator, is it a true deep bite or a pseudo deep bite? Or is it a case more favorable for your functional appliance therapy? So another more important to read is the Clark's cephalometric analysis, the Ricketts triangle and the facial rectangle, very well explained in the Clark's book. So with this, a summary of cephalometric analysis should be made. Sagittal discrepancy, where it is. It could be a normal maxilla with a retrognathic mandible, or a prognathic maxilla with a normal mandible, or a prognathic maxilla along with a retrognathic mandible. All cases are not very ideal cases with a normal maxilla and a retrognathic mandible. Moyers has given 6 sagittal types of class 2 malocclusion with 5 vertical types. So it could be any of the combinations. So we need to find out in my particular patient, where is the sagittal discrepancy? How is it? Then the vertical pattern could be vertical growth direction, could be horizontal to average to vertical. Then the mandible could be retrognathic or retroposition, that you need to mention in your summary. The incisor inclination, and yes, the airway analysis. The McNamara's airway analysis, the upper and the lower airway space. It has been seen with retroposition mandible, the airway is compromised, and with functional appliances, you do bring about improvement or modulation in airway. So airway does improve, and that's the best time to improve the airway during this growth phase. So airway also should be measured. At times you should look for, if the upper airway is compromised, decreased, is there an adenoid enlargement? In a cephalo, if you see very well, in the retropalatal area, you may see an oblique-like shadow over there of the adenoids. Often it is missed even by an ENT surgeons also, which is my experience. So you should see that also in a cephalogram. So we have seen the indications of the functional appliances till cephalometrics. Now, is there a severe crowding or rotation? A severe crowding or rotation may interfere in the path of forward movement of the mandible, and therefore it is said that there shouldn't be severe crowding or rotation. Now, if you have a time in hand, a sufficient growth left, you can give a pre-functional appliance, or else it can be treated later on. Then orofacial dysfunctions, we will cover it, the VTO and the good patient's compliance. So the orofacial dysfunctions will fall in the functional analysis. Three aspects have to be studied in the functional analysis: examination of the postural rest position and maximum intercuspation. And this, I think, will be very well covered by our eminent speaker, Dr. Toshniwal sir. The examination of the TMJ has to be done, and the examination of the orofacial dysfunction. What do we want to see in the TMJ? Around 41% of the cases in the age group of 8 to 14 years have a TMJ dysfunction. And early elimination of the functional disturbance will correct the TMJ problem. It will eliminate the TMJ problems. So in TMJ examination, you need to ask to the patient along with the examination, is there a clicking, is there a pain, or is there a dysfunction? And the clicking could be an initial click due to retruded condyle in relation to the disc, or it could be a terminal click where the condyle has moved too far ahead anteriorly in relation to the disc on maximum jaw opening. So you need to assess how is the click also, and how much our functional appliances will work. They definitely work at the TMJ to bring about a harmony between the condyle, the disc, and the glenoid fossa. And we had carried out an MRI study long back in 2005. And with that, we studied the relationship of the disc in relation to the condyle and the fossa in both bionator and twin block. And definitely there is a good harmony post-treatment with these appliances. Then examination of the orofacial dysfunction. Is there an abnormal muscular pattern? Because that is the prime etiology for dysfunction. And you need to look for the swallowing pattern, the tongue posture, function, and size. Is there a habit? Because habit leads to this abnormal muscle function. It disturbs the equilibrium between the intraoral group of muscles and the extraoral group of muscles. And that is then responsible for the incompetency or the hypoactivity of the orbicularis oris also. The breathing pattern changes from oral to oronasal or a mouth breather. So we need to thoroughly examine for this, because these cases with abnormal muscle function, we are trying to bring about a balance in the muscle function with our functional appliances, and the appliances work best in these cases. Then a VTO, we ask the patient to take the mandible forward and assess it. And the VTO, yes, in few of the cases, you will get a very fine positive VTO, but as I earlier mentioned, it could give also at times a Bimax look. So that means after the functional appliance therapy, you can correct it. So yes, so you are ready to, with all the indications. Some will be in favor of functional appliance, some will not be in favor of functional appliance, but that doesn't mean that I will not give an appliance. No, what is not in favor, how to overcome it. That we will try to find out how to overcome the parameters which are not in favor of functional appliance. So that you should be prepared with the answers, and we will take it also. So which functional appliance then? So is it the activator, bionator, Frankel, or twin block? Often the students directly jump, what I have seen in the recent years, to a twin block. I know it is a very versatile, a patient-friendly appliance, and we do give during 3 years post-graduation this appliance. But that doesn't mean that the earlier appliances, the earlier masters of functional appliances, their thoughts did not work. With due respect to them, those appliances worked till the Clark twin block appliance came up in 1982. So we need to also give a thought to activator, bionator, and Frankel. Though it may be not a choice of appliance, you need to then justify it, why it is not the choice of appliance for this particular patient. So therefore, it is why the philosophy of the appliance and the mode of action. So I'll just brush up with the knowledge. You all know about it. So activators given in mixed to early permanent dentition stage. It is preferred when the arches are well aligned. See, when the arches are well aligned, the patient is in a mixed dentition. When you hand articulate the models, no posterior crossbites develop. Then you can guide by selective guiding. You can guide the eruption of the teeth, the permanent teeth erupting into proper interdigitation. So, and it gives a skeletal correction. So it is given in class 2, div 1 and div 2 cases. Then the Frankel appliance, a gymnastic appliance, preferred in the early to late mixed dentition stage, where there is a functional retrusion, where you can see that the hyperactivity of the muscle, especially in the lower arch, is causing a crowding in the lower anterior. So it will eliminate the hyperactive muscles and will bring about the arch development. Though there are studies in the literature now recently, Frankel appliance has been compared with a twin block also, even in the early permanent dentition. But to my knowledge, this appliance will work best when there is a functional retrusion, when the patient is in this growing phase of mid-mixed dentition to early mixed dentition, and it will bring about a proper arch development along with it. So abnormal perioral musculature, it corrects, and when there is excessive interocclusal problems. Bionator, Balter's bionator, he has given more importance to the tongue. The tongue, the center of the reflex activity, and should be given in the mixed dentition and the early permanent dentition, especially when the maxillary canines are erupting. When the class 2 is due to a habit which has caused the tongue to be lowered down in the oral cavity and the maxillary arch is narrow and there are TMJ disorders. So it brings about an equilibrium. The palatal bow will guide the tongue forward anteriorly, will bring about a transverse development of the maxilla, a passive expansion of the maxilla. There's a difference with it. An active and a passive. The passive expansion is a stable expansion. A good arch development will take place to which the mandible will catch up and the results will be stable. So in such cases, bionator should be preferred. Then the William Clark twin block appliance, early permanent dentition, and he has given importance to the forces of occlusion being the key factor in making it a class 2 malocclusion. The distally directed forces of occlusion has led to the class 2 malocclusion. So the inclined planes will guide the masticatory forces, will harness the masticatory forces and will bring about a neuromuscular adaptation. Yes, it is a two-piece appliance, a simple, comfortable, versatile, aesthetically acceptable, permits jaw movements, and therefore it is more preferred an appliance today. If we compare the activator, bionator, and the twin block regarding the mechanism of action, activator activates the muscle, bionator modulates the muscle, and the twin block brings about the proprioceptive stimulus. Versatility, yes, the twin block is more versatile. The wear time for the activator is night time, for the bionator day and night, and for a twin block 24 hours, even during mastication, because those masticatory forces will bring about a correction in this appliance. Patient acceptance, yes, twin block more accepted, then a bionator and then activator. The vertical opening in activator is adequate. In bionator, you have to keep it edge to edge because it is a loose fitting appliance in the mouth. The patient has to hold that appliance in the mouth by keeping the lips closed. The lips are activated with that appliance. The muscles are activated. The tongue is modulated, and that brings about a correction. So vertical opening should be minimal in case, or edge to edge, we say in bionator. Regarding the skeletal and the dentoalveolar changes, the activator brings about both. More is seen with the dentoalveolar, around 70%, whereas with a twin block, studies have shown around 50-50 correction, and some studies have shown even 70% skeletal correction. Now, apart from this functional appliance, also give a thought to the maxilla. At times, the class 2 could be because of the contribution of the maxilla also. It could be a prognatic maxilla. So that also should be kept in mind. Is my maxilla prognatic? Many times it happens students are not well prepared, and on the last moment we ask them to put a headgear into the appliance. So study it. If there is a maxilla is prognatic, if it is due to the prognatic maxilla and a retrognatic mandible, often in such cases there is a vertical growth pattern. So in that case, we have to add a headgear also into it, an orthopedic force to restrain the maxilla, to hold the maxilla in a sagittal as well as in a vertical. So for that, the CR of the maxilla you need to locate, and the line of force, how to pass between the CR of the maxilla, the dentition, and the CR of the molar. All the center of resistance has to be considered when planning your headgear force. So this also students should go through. So yes, with all this, you have gone through your case now, and you now know this patient is best fitted for a activator, Frankel, bionator, or a twin block. But you have to have an appliance which is customized for this patient. It should be tailor-made. At times, it may not be a very ideal case for a one appliance. Along with positioning the mandible forward, your mentalis may be still hyperactive. So in such cases, you may have to add the Frankel lip pads so as to bring about a periosteal pull and a bone deposition over there. So the component approach is given by Frankel. So you have to add the components of other appliance. You can put an expansion screw that will bring about an active expansion if the arch is narrow. Then you can put a tongue spikes where the patient has a tongue thrust habit. If the lowers are proclined, no spaces are there, then tapping of the lower incisors should be done. But if there are spaces and the proclination is there of the lower incisor, you can put a labial bow also in that particular case like this. Also, you can then give, if whether to give a lip pad or a lip bumper, that also has to be decided. Now, if there is a hyperactive lower orbicularis oris, after bringing the mandible forward also, you find that there is a hyperactivity of this orbicularis oris, the lower lip. Then in such case, you can give a lip bumper so as to screen away this hyperactive lower lip from the dentition and allow the mandible and the dentition to come forward. So the appliance should be custom made, and you should plan all this while presenting it to the examiners. When there is an increase overjet, though Clark says in a twin block, you can jump by 10 mm. But when you jump it, the muscles in such cases get fatigued. You'll get less of a skeletal correction. A stepwise advancement should be done in such cases. And we have come up with this modification by adding a jack screw. Then patients which are non-compliant, though Clark says initial 15 days, you can cement an appliance, but you can do this modification by putting a band on the molar with a lingual sheath in a vertical direction and a double back arch wire in your posterior block. And that will fit into it just like a fixed twin block. So this also can be designed in your patient. Yes, so you have now the appliance tailor-made for your particular patient. You know the mode of action of that particular appliance. Where are the changes expected? The question will be, how does it work? Graeber has given 7 components. It will work at the condyle. So condylar growth will be there. Fossa adaptation will be there. Elimination of functional retrusion will be there. More favorable growth direction will be there. Differential upward and forward eruption of the lower buccal segment. Withholding of the downward and forward maxillary growth and maxillary headgear effect. So mandible, there will be an increased height of the ramus, increased length of the ramus, and anterior relocation of the mandible. Maxilla, yes, there is a restraining effect. Around 0.5 to 0.7 has been seen. A and B angle will improve. The glenoid fossa remodeling will take place along the anterior surface of the posterior glenoid spine and the posterior surface of the condyle. This is very well explained in the growth relativity theory by Woodruff. Then the maxillary dentition, there will be lingual tipping of the maxillary incisors, holding of the maxillary molars in a vertical direction, and vertical dentoalveolar development of the lower posteriors in the mandible, and the label tipping of the mandibular incisors. Soft tissue definitely improves with this functional appliance therapy. And the airway, yes, airway does improve. So there is enhancement of mandibular growth in the skeletal class 2 malocclusion. There is a neuromuscular adaptation. Airway modulation due to growth is inherent with the mandibular advancement. And it has been seen that patients who are at risk of sleep apnea, in those cases, there is a drastic improvement with the functional appliance therapy. So to conclude, the functional appliance is a tool to treat growing patients with a skeletal class 2 malocclusion. Case selection should be proper. The choice of appliance should be based on a proper diagnosis, their philosophy, benefits, and limitation. The appliance should be tailor-made for your patient. The success of the treatment is totally dependent on patient's cooperation and the timing, the treatment during the period of growth. Dramatic facial and skeletal changes are seldom seen with a fixed appliance, are always seen or routinely seen with a functional appliance. You get a combination of orthodontic, 70% orthodontic or dentoalveolar correction, which we say, and orthopedic or the skeletal correction, 30 to 40%. A second stage of fixed appliance is necessary because functional appliance is meant to bring about a skeletal correction, individual tooth movement, and proper intercuspation of the dentition will be brought about by the fixed appliance. What you have achieved with the functional appliance, it will be retained by natural intercuspation, the proper cusp to fossa relationship of the posterior teeth that will hold the correction later on in life after your appliance therapy. So good posterior fit is necessary after your functional appliance therapy. So believe in the appliance, believe in yourself also. The outcome of both will be definitely positive. These are the books which you need to chew and digest. You all know about it. And good luck to all the students who are appearing, just who are at this finish line, or who will be appearing 24 months later also. So good luck to all.